Hey, Brendan.
Good evening, fellas. How we doing?
Doing well.
How are you?
Great.
Hey,
How
you got a hard
go?
stop? You got a hard stop, Brennan?
Fortunately, I do. I could try and push it to 9:15.
We could wrap it up in 45 minutes, no?
I'm good.
How long did
whatever
it
you
take
think.
last time? It was 1 hour?
Yeah, we did over an hour.
Is there a delay? Is there a delay on your end, Dr. Wahan?
For me, like my delay?
Oh no, you're good. You're good. Okay.
All right.
Maybe it's the Western time zones.
I've been having some weird sync issues on some of my stuff. Yeah, there is a delay. What the hell?
It just seems like it's with Brandon.
You think I?
No,
you
when
think I have a delay?
I'm talking, there's a little delay. You can fix some of that, but it's a kind of a pain in the butt in post. But there's a little button to click for sync issues to fix that. I've used that before for people. Why is there a delay?
Maybe it's because the 3 or 4 of us are on. Yeah, it's all right. We're good.
What's that TikTok noise in the back? Who's got that clock?
Is that my clock? Let me go get
You have
that.
good ears.
Do you want me to? Because that usually gets taken out with the post production on the Riverside. I could.
Yeah, no, I don't care. It's a nice metronome.
Is it bothering you? I'm in
I
the
didn't-
house I grew up in. It's my dad's, and we have like the grandfather clocks around and stuff. Is it okay? Is it that bad?
No, that's fine.
I'm good.
Joe, can you move closer somehow to the computer?
Yeah.
Just so your head's like aligned with.
Joe, where's your salad bowl?
It's behind me, right there. I am using my ring light though.
You know, we're recording, guys. You know that.
Are we actually?
Yes.
Little sneak attack.
How's that?
Yeah, your head looks more proportionate now.
Okay, good.
Thanks. Yeah, that's good.
Hey, so Dr. Amir and Dr. Joe, I haven't got to get you on here or speak with you guys. Thank you guys for inviting me on the BackTeeth boys.
Teeth boys.
BackTeeth in the house, baby.
Back
I
to
voted
the
for Led Zeppelin. That was my vote. And U-Tooth, but BackTeeth
that's a
boys
good one.
won.
BackTeeth's
They're all pretty good.
BackTeeth is good.
Back teeth.
Yeah.
How was everyone's day?
I just got home from work.
How was
You
work?
work
Everything was
late.
good?
You work late, Amir.
Yeah, it's just they shoved one more case down my throat at the end of the day, and he was just one of those bleeders, and I'm like, fuck, I gotta go. Like, stop bleeding.
Did you guys all work today?
Yeah. It's starting to slow down for me. I think the kids are back in school, so it was pretty chill, uneventful.
But Brennan, you started working this week, dude.
Oh yeah,
It's like
congratulations!
It's like your second
Yeah,
or third day of actual work. What's going on?
You're the story. 100% you're the story.
No. Am I a neurosurgeon now, guys? I don't know.
Guess so. Yeah.
Day two. Yeah. A lot
I
of
was gonna
insurance.
say, yeah, day 2. That's crazy. Is it weird? No.
It's what's weird is working on a tooth for 45 minutes and they're like, yeah, that got you $76 from Fidelis, and whoa, oh, yeah, that's lots to swallow.
Got it. Yeah.
Volume, man. It's volume.
Wait, they pay you guys $76 for an extraction? How does that work?
No. Some
Fidelis was 76 for just extraction, erupted tooth.
really?
Yep, that's
And
what the office
what's-
manager told me yesterday. Fidelis is one of the, I guess, New York insurances.
Like a
Hasn't made
state,
it over to
like
you
a
guys
state
yet.
plan? It's a state plan or something?
I'm not sure. I'm really not
right.
sure. I'm just
Yeah.
learning about all this stuff, and I'm
Yeah.
shocked.
Yeah.
No, it should be more than that, depending. And Joe would know.
I'll have you know, I do nothing the same 20 years later than I did my first year. It's completely different.
In what
Yeah,
sense?
your first year is different.
Yeah. In what sense? I was trained using Brevitol. Have you guys used Brevitol ever?
Nope.
I have
No.
no idea what it is.
I hated it. I mean,
Hiccups, right?
it's kind of a
Coughing,
an alternative
hiccups.
to propofol. Yes, exactly. And I don't know, poor patient selection when I was first out. I felt compelled to do every case that came across my desk. And as I got older, saying no was a superpower. So knowing when to say yes and when to say no. But yeah, man, getting away from Brevitol. I mean, I love propofol. It's the best drug ever, at least in my hands.
I like Presidex now. I started using that this last year. That's awesome.
How's the price of that, though?
It's not bad at all. It's multi-unit, multi-dose vials, and it's great. It's so good. It's really helped those difficult sedations.
So one bottle will do 4 patients, Serv. What's the math on that per bottle? Because I've got a bottle. I've not tried it yet.
What's your dilution on it?
I don't remember.
200. Is it a small vial, like a 200 per 2 cc's? 200 micrograms per 2 cc's, maybe?
I think so, and I think when I first got it, I remember this will fill 4 syringes, so 1 for each patient.
Depends how you dilute it.
Yeah.
So we take a vial of 200 micrograms to 2 milliliters of Presidex, and we take a 20 cc vial of normal saline, like a sterile vial. draw out 2 cc's of the normal saline. So now there's 18 cc's of saline in that vial, and then put that 2 cc's of that concentrated Precedex in that saline vial. Shake it up a little bit. Now that gives you a dilution of 10 micrograms per cc. So I try to give every patient around 20 cc's of Precedex, or 20 micrograms of Precedex, which is 2 cc's up front. I do like a 10, a 5, and a 5, just depending on what their heart rate does, because it will give them some bradycardia. And then I do that with 2 of Versed, 2 milligrams of Versed. And then I wait, and everything looks good. Little Versed, fentanyl, and/or ketamine and propofol.
Okay.
And they're asleep pretty much the whole time, and you don't have to give a lot more after that.
I hear it's great in children.
Yeah, it's great. It's really good. There's no breathing issues with Precedex, which is great. So you're not going to have respiratory depression. And it's an alpha agonist, actually. So it will give some bradycardia. So it's really good in those patients that are tachycardic from the beginning or hypertensive. Like it will drop that for you, which is nice. So if someone's tacky, like real nervous, and the one needs before you even start the IV, those kids that are just real nervous, or adults too, I guess. It really helps with that too, which is nice. Yeah, we can talk about it later. I can tell you how I use it. It's great. I love it. Now I couldn't imagine without it. So I just started using it like less than a year ago.
Does everyone want to give a smile before I'm going to take a picture of the... Joe, you want to give us a smile?
He is.
This is my smiley face.
Got it.
All right.
The BackTeeth boys.
Brendan, what do you use? What's your cocktail?
When I finally get the license, the anesthesia license.
Oh, you don't have the anesthesia license yet? So you're just doing locals?
Just locals right now, ripping through locals.
Man, you guys are slow in New York, man. Jeez.
Yeah. The more taxes, the slower it gets. So.
Man.
Welcome to my world.
Yeah, you're up in Canada.
High taxes, no sedation.
Toronto, baby.
Just the usual. I mean, in residency, it was you give them 3 to 5 of Versed, and then it depends if they're younger, maybe like 25 of ketamine, and then propofol from there. Otherwise, fentanyl, 50 of fentanyl, and then push pro from there. Yeah, that's usually my go-to. So in the practice, I don't know what they're doing. I know that the boss gets them really deep, a little deep. I'd be nervous the whole procedure. I don't know how he does it, but no, the Precedex that we used in residency was phenomenal. I mean, it was the cleanest wake up, so that would be ideal.
It puts them into REM sleep, so it's interesting. Like they want to be asleep, so like you wake them up a little bit, but they just want to go right back to sleep, which is nice to have, rather than wake them up and now they're up and now they're freaking out because their heart rate's up or whatever. I mean, that can still happen. It's not a cure-all, but it really does help with that, which is nice. But it does take 15 minutes to work. Some people say 20 minutes to work. Like you'll see the bradycardia right away, but in like 15 to 20 minutes, that's your prime time where Precedex is now working for you. So you have to wait. So some people give it like 15, 20 up front, and then they wait 20 minutes before they start. Now they're in that zone, and then they can just start giving the microdoses of other stuff. So I don't know. It's interesting. Very interesting.
That's pretty good. Yeah. And Dr. You said Brevital. I was just going to say, with the Brevital, didn't they get a lot of hiccups with that? Because I worked for a surgery group.
There was a lot of hiccups. To me, I experienced a lot of laryngeal spasms with it. And gosh, I vividly remember my first year. God, it must have been 4 months in, and I had a guy who was a smoker. I shouldn't have, given him so much, snowed him. Man, his stats went to the 40s like that. And, I had to bag him, and, everything was fine. Everything was good. In hindsight, I wouldn't have sedated this guy, but I remember thinking, how am I going to do this the rest of my life? It was so stressful. But I was talking to a friend of mine who does oral surgery. He's been out for about 20 years as well, but no kidding. He said it took about 10 years for him to really kind of get his technique down to where it is now. And I kind of agree. You try these little experiments with patients when you have enough volume, you have more of an idea of what direction you want to go into. But I think it takes years to really figure out your quote technique.
Especially after that first year, Brennan. Like you're gonna be like what Joe was saying before, like you're gonna do stuff this year, and then you'll find out next year, like your efficiency is different. Everything's a little bit different. You're kind of seeing things differently in a way. It's nice. Not that, it's a bad year. Your first year, everyone goes through that, but it's nice to learn a lot of stuff in the way you want to do it. Because between residency and private practice, there's a lot of differences, You just got to get used to some of that stuff. I was like, wow, someone's cleaning my room for me. Like I was just so shocked when I first started working.
Me too.
Assist myself, or like, it was just weird. I was like, can I help you? They're like, no, we got it. I'm like, okay. It was just awkward at first. I remember that.
It's
But
nice. It's a great difference. Yeah.
yeah, we
Yeah,
had
my
some.
first
Oh, go ahead,
my
Joe.
first my first associateship, they had a very, I guess, uniform way, the way they did things. So they told me I had to sit down. All right, they told me I had to use these drugs, which was different. Yeah, I'm glad I went through it. The
You sit
handpieces I
down?
use.
You sit down for
Yeah, I
surgery?
didn't sit down at all during internship and residency.
I've never tried that.
I would try it, Brendan, if I was you. I mean, it'll save your back. Your 50-year-old self will thank you. But I think it's
It's not all
pretty.
those lat pull downs you do on your stories that help with
Say it
that.
again.
It's not all the lat pull
Right.
downs you do.
Exactly right. Exactly right. But anyways, yeah, it was helpful. I would try it. I'm not sure how it is in your practice if they make you use certain drugs or cut you loose, but they made us do things a certain way in my first job after residency, and I'm kind of glad they did.
Huh. You know, the
Yeah.
one thing I'm worried about is, you know, like you start sitting down when you take out teeth and you start sitting down when you pee. And then I'm just kidding. I'm just kidding. I'm kidding. No. There was an attending that told us to sit down at the VA, and he was my favorite attending of the program. So no, I totally hear you on that. I'm still working on adjusting to like trying it like more than you know, a couple times here and there. But
I've
just
never
get
even
so
tried it.
used to standing, you know.
Yeah,
But it is
Yeah.
good on your back. Yeah.
There's a stool, like a saddle stool you should get. It's expensive, but you're not really sitting. It's just kind of hugging your cheeks, that sort of thing, but enough to take the pressure off your lower back. So I'd recommend it.
You use the saddle one?
The saddle, is that what you said?
Is that the one you use? Oh, gotcha.
Did you have to get a mold of your butt cheeks to make it fit better?
No,
You
but that's a good
ordered
idea. Maybe that's our like retirement idea. I've never thought of that
Like-
though.
Do we have an alginate tray for this?
Gotcha.
No.
Serv, you can go do personalized butt impressions. That'll
Very
be less-
personalized. They were very
Right, right.
personalized. Yeah. Yeah, that's why we do digital scans. We don't do alginates.
Right.
But nice, man. So Brandon's finally working. Getting the people coffee. I saw that. That was nice.
Yeah, coffee, donuts.
Yeah. So we did a BackTeeth Boys with 3 of us. Now there's 4 of us on the BackTeeth Boys, which is great. More people to help out because we get, like, you know, you probably get them too, like clinical questions here and there. I know all of us do. It's crazy. Like sometimes you get the same questions like over and over. And I think Amir was saying that people were asking a ton of on like coronectomies. Did you guys do a bunch of those in residency? I didn't do any in residency. Everything I've done with coronectomies has been post residency.
Yeah, I did in resident. I'm seeing Dr. Amir's got an Audemars on. Oh my goodness. I saw that.
How'd that happen? I didn't
Getting
see his arm.
distracted.
Can't
Yeah,
even see his arm over there.
we did a ton of coronectomies through residency. In fact, we did a mission trip for a week in Jamaica, and we did a coronectomy on a patient there with like just you. They had one
Dense
nomad, so
bone.
it was like
Yeah.
yeah. But yeah, we did a lot. Did you guys do a lot?
I do more now. I mean, in the past 5-10 years, I've done, you know, more and more of them actually. But yeah, what were they asking, Amir? There were some questions like your steps or your protocols for coronectomy, basically.
Protocols for coronectomy, indications, contraindications, burrs. I'm actually curious to know what burrs you guys use.
Yeah, I use like, I guess a total of 3 burrs for it. One is the normal burr I use for sectioning teeth, which is like a 703 or a 1703. I like the 1703s now. They're a little bit rounded at the ends than the 703s, and they cut smoother. So we've switched to those. I used 703s for years, up until like a year ago, where we all got 1703s now. But they're pretty much the same kind of burr, just a little bit different at the tip. And then that's my sectioning burr for most things. And then once I cut that crown off, sometimes you'll have like on the mesial, when you're doing a coronectomy, like there's a little lip of enamel that goes up against that adjacent tooth that's really hard to get to. So I might use like an 8-round burr just to sneak that in there, you know, because I use a straight hand piece. I know Joe's use like an impact air, and so do you, Amir. We have straight hand pieces in our offices, so we use the BN Air Chiro Pro straights basically, and so I don't have any sort of contra angle or anything I can get in there easy with. So I'm using the straight hand piece, and I try to get that 8-round burr in that little spot and kind of flick that lip out, and then I use this big round burr. It's not, if an 8 is like an 8. This is like the size of a pea, like a garden pea. Like it's big for what we're doing, but that's really to smooth everything down, like all the edges and the coronectomy part itself. And then that's the final thing. And then I put the PRF on top, the fibrin plug. That's usually how I do it.
Oh, you put it on top. Okay.
Mm-hmm.
Huh. We usually just would close it up after. Same exact technique. It was a straight handpiece in residency. Now we have the contra angle. So I don't know what the exact burrs are. This is my second day using it in residency. It was only straight handpieces, but I feel like for the coronectomy, when you're cutting the crown off and you're making that section, it's nice to get as low as you can as you angle it towards, the lingual. And then if you do have any high remnants left over, it's going to be on the buccal where you can see it, and you don't have to look as much around that, the back of that tooth. But there's always going to be that little lip that just kind of sticks up and hugs up against, whether it's 18 or 31. A round burr just gets behind, the second molar nicely. You just, like you said, flick that out. And then I would just keep the same round burr on, and then just make sure you want to get it like about 2 centimeters below the crest of the bone, and then just irrigate it, close it up. That's all we would do. The PRF is nice. That's a nice touch.
Yeah, I usually just do the red tube, which is just the fibrin tube, and then just put that on top. So I don't know.
It's interesting. There was once a patient I actually suggested to do a coronectomy for, because 100% I was anticipating they're going to get some sort of paresthesia if we were to remove the tooth. And then I always tell patients, because I tell every single one, I say, I am not a specialist. I am not an oral surgeon. I am a dentist by training. I just have a lot of experience with wisdom teeth. But if you want to see a specialist, you can. And I give that option to every single one. So I sent it to an oral surgeon. It was an office that I don't usually go to, and it was just a close oral surgery to them. And the oral surgeon had thrown me so far under the bus and said, coronectomy is malpractice. I can't believe the dentist had suggested that. You're leaving tissue behind. It's not acceptable treatment. You're either going to remove the tooth or not.
Guy?
No, it's a younger guy too.
Oh, really? I don't know.
Crazy.
There's lots of studies on it now. Even
I know.
In our journal, quite a bit.
I know. I was going to send some of those.
Let's get this guy's name on here. Let's leave a couple Google reviews.
Yeah, that's weird. That doesn't make sense. And to throw someone under the bus for that, I mean, you're really looking out for the patient when you offer that, honestly. It's, and there's indications for it. I think people had more questions like, when do you do it? When do you don't? I mean, one of the real contraindications, if you have root movement, don't do the coronectomy. You don't want to leave a mobile root in there because that's the bigger chance for infection, things like that. Yep. So sometimes I go in with a plan of, removal of the tooth or coronectomy, depending on what we find in there. And patients know it could be either going in. And, when they wake up from surgery, or if they're, whatever, we, let them know the reason. But I do that sometimes too. If the root's completely fused, I'm like, then we're going to probably do the coronectomy on this case, So, yeah.
Large caries, right? That's a good contraindication if they're, they're just going to leave the roots get infected anyway. Yeah. The roots, definitely for that.
Would you do a coronectomy if, let's say, there's caries, but there's no pulpal symptoms?
I've done it.
Because that was my dilemma last week.
Yeah, I would. I think the disease is the caries, and if it's an older patient, just removing the crown, and just like you guys described, go a little bit under the crest of the bone. Make sure there's no movement. I think you close it, it'll be fine. I don't think that's wrong.
Yeah, and there's some other questions I think on, I don't know if you guys do this in Canada or even on the East Coast versus West Coast, but do you get CT scans on your wisdom teeth cases, or is it just 2D imaging like panos and PAs and things? What do you guys normally do?
We talked about this the other day. I know, Amir, you said that in Canada, everybody gets them. I just don't think that's practical. And I think that the conversation we had was that if someone else is paying for it, with universal healthcare in Canada, it's pretty easy to do. But with me, and Serv mentioned that as well, that it's hard for us to order something like that on that many people. It's just impossible. So rarely do I do it unless the patient's older and it's really, really ominous. And maybe the patient's personality too factors in, believe it or not. If they're really skeptical, or if they're really just kind of go with the flow, hey, I trust you, I'll do what I normally do, which is usually not take a CBCT. Right. But if they're skeptical, I'm going to get all the information I can. I'm going to over communicate. I'm going to tell them exactly what you said, Serv. There's a chance I may leave it. There's a chance I may take it, depending on if the root is mobile. So those are the two scenarios. So rarely, but usually in older patients.
How often are you doing coronectomies then if you're getting the Panorex? You're saying before, right? Panorex before, and then less often the CBCT?
I'm even talking CBCT for just routine wisdom teeth.
Yeah, rarely. Rarely for me.
Because the indications, right? You got the shading of the root in the canal. You got deflection of the canal. Can you see the roof of the canal? If say 2 out of the 3 or more are there, then I'm like, I want a CBCT. I don't know. You guys, it's usually.
Well, I still don't. You guys
Same
do.
here. I just don't think that when coronectomies were when they first were a thing, I would do it. But I learned that it really didn't change a lot of what I did. It just didn't.
That's how I feel.
And then putting that bill on the patient, a lot of times it's justifiable for sure. You can do it, but at the same time, I thought I trained my entire training with no CBCT for wisdom teeth, so it's just different.
I just think about it both ways. Like you go through all that. You're like, oh, you look at the Panorex and you're like, oh man, that nerve is really close. You know what? I'm going to recommend we get a cone beam CT scan so we can really localize where this nerve is. And then let's just say you do the surgery and they still have a paresthesia. And now what? Like, well, you got the CT scan. Did you know? I'm like, yeah, we knew it was close. It happens, right? It can happen. Obviously, you do enough teeth like that, you're going to see stuff. So I'm just, in my opinion, like it's not going to change the way I approach the case, unless I see something weird on the 2D. Like there's something weird going on here. Maybe there's like a third, fourth root, something dilacerated really bad. I mean, or there's some pathology or something that's different. But if it's for, wisdom teeth and things, even if it's a deeper wisdom tooth, I normally don't get it.
Yeah, and you have that conversation with the patient, while after you take the CBCT, you look at it with them and just say, to me, I'll just say this probably is not going to change the way I do things, but it's good information to know. And like I said, we may leave the root in, we may take it out. And the patients, they understand that. That resonates with them, I think, just going over it with them. So whatever you do, I feel like after that, you're good, depending on what happens, despite what happens.
So here in Canada, it's a lot more strict. Kind of like our taxes. But here, if, like, for example, as a general practitioner, if I have a nerve injury case and if it ever goes to the dental board, the first thing they're going to ask is, did you have a CBCT? Was it going to change anything? Probably not. If it was a challenging case and the tooth needed to come out, still would have probably approached it the same. But the very first thing they ask here is, did you have a cone beam? And even some of the oral surgeons I work with, they refuse to take out wisdom teeth without a cone beam. Like the ones that have it in their office, they might not pass the charge to the patient, but most of the time, most of the GP offices here don't have a CT scanner. So we have to refer them out to a radiology center to do it. And it's like $350. It's not cheap. So a lot of times the patient will call and say, do I really need this scan? And my answer is, it's on you. If it's a risk you can live with, then we can proceed without it. But if it's a risk that's going to change your life, if it's something that's going to change your career, because I actually had a patient once, and she actually hadn't told me this information until halfway through the surgery. But she said, Doc, I'm really, really worried about losing sensation to my lip or my tongue. And I said, don't worry, it's going to be fine. She's like, no, Doc, it'll ruin my career. And I said, I'm so sorry, what do you do for work? And she said, oh, I'm a professional food taster for a huge manufacturer. And that's all I do is when they want to create like packaged food, I have to taste it. I sample all this stuff. And I'm like, you couldn't tell me this before this surgery? Yeah. And it was a bad case. It was a case I was actually anticipating some maybe transient paresthesia.
Your nerve's right here. Here it is. Put it back in now.
It looks okay.
Oops, is it this one? Is that granulation tissue? Oh, nope, never mind.
Yeah, I mean, my experience is permanent nerve damage is rare. I mean, as long as I've been doing this, I don't know, maybe one or two. I mean, I have it, but my experience is it's usually transient and temporary.
It's because you get all the poppers, Joe. I've seen your video. You get all those poppers.
So?
How do you get all those? I don't understand it.
I mean, those are just I mean, I told you about that guy who I did his son. He was a dentist. It took me 45 minutes for one tooth. So it's a highlight reel.
I know. It's a highly curated thing.
Right.
Social media is a highly curated thing. When you see people's
100%.
cases, it's like, it's highly curated. You're right. You're looking at other people's highlight reels, basically.
Right.
Like they're not going to show you all the crap, day in and day
Fun
out.
fact, if my videos are muted, then the patient was screaming. So those are stressful days.
Yeah. That's a fun
If my
fact.
videos are muted, it's usually because I'm screaming.
Oh man. But yeah, if my videos have music in them, something's happening. I'm not gonna play the audio there. That makes sense. Or there's some high level editing going on.
Right.
That's funny. But yeah, so now that I was gonna ask you, Brent, now that you're working and stuff, like I mean it's only been like 2 days. Are you gonna be taking clinical photos, or you're still gonna like just get the flow of things? Like how do you have any idea?
I'm not.
It is a lot of work. It is a lot of work to do all that.
Yeah. I mean, I'm gonna get a photographer come in and do like, you mean clinical photos of like the patient in the
Cases,
mouth, the videos
no
and stuff.
cases, things like that.
It's a lot of work. It's a lot
It
of
is a lot of
work,
work.
and I don't know. I'd rather just
Do what
talk
you do.
about complaining about insurance, and I don't know. I like to say how it is. I'm not going to pick the highlight reel. You know, I don't know.
Yeah, I
I'm
agree.
walking out of work. I'm going to say yeah, yada, and then go back to the car, cut out all the ums and ahs, put captions
Yeah,
over it, and post. It takes 10 minutes. You know,
yeah.
I don't know.
No,
I
that's nice.
could.
It's nice. Video's nicer.
But then it takes a while to edit when you're doing that, right? You know, it takes a long time, and
Yeah.
it could be done just,
I
you
don't
know,
know
and
how
then
Amir.
you're doing the work. Then you need to get it sent, or someone else needs to take your camera and do it.
Yeah, I record everything. It's a pain in the butt. I know Amir finds these cool audios he puts on his. I don't know where he gets all those, but those motivational audios you throw over your videos sometimes.
It
You know
goes
what
with
I'm
my
talking about? How do you find those? You just search for something. There's like a site you go to that has a bunch of cool
no,
ones.
it's just in my explore page, and I like, before bed. I don't know how many of you do all this, but before bed, I scroll for like 45 minutes, which is a terrible thing to
Doom
do, but I
scroll
still
every
do it.
night.
Yeah,
Yeah, yeah.
and some of this stuff, like, it clicks and it gets me thinking, and then if it's just repeating in my head over and over and over again, I'm like, well, maybe I'll put this on a reel next, and then
Yeah.
I'll find a case that might match that audio.
Got it.
I think I did one 2-3 years ago, which was like a very famous uh, phrase out of a poem, which was about finding a path in a difficult situation. And then I posted it with a case that was a very difficult situation.
Very nice. And you just had one blow up on TikTok. I don't know if you had an audio on it, but that was like 3.5 million views or something on that one. That's
Yeah,
nice.
that one went viral. It's
Yeah.
got
Wow.
3.6 million views. But there was no
Nice.
audio on that one. That was just,
Yeah.
and
That's
I
awesome.
wasn't even swearing in it, so it didn't go viral for the wrong reason.
That's
That could
awesome.
be the most watched extraction in history. You never know. It could be.
No, I'm sure there's other ones out there.
Yeah.
There's got to be something. Yeah, there's got to be more. Yeah, like my highest on TikTok, I think, was 2.8 million. So you
Oh,
smoked me.
wow.
You
I
smoked
had
me.
no idea.
Oh, wow. Shoot, I didn't follow. You got a blue glove here. Let me get you. 3 point. Oh, wait, no. Facebook. Here we go. Yeah, for viewers who are really showing my.
Brent's got the privacy screen going.
No. It's the regular.
Yeah.
It's probably not going to zoom in, but it's this top right one for viewers. Top right in the screen, left on my phone. Top
Oh,
left.
that's
That's
my
the one.
dude.
3.6.
Yeah.
This is you. Yeah, I said that. This is you.
I was like, wait, that looks really familiar. Those blue gloves.
That's you, man. Yeah, nice gloves. Kind of hot.
So I've left one of my surgical motors, like handpiece that I need for horizontal impaction tomorrow, and nobody in that clinic can deliver it to me. I've sent like 3 Ubers to this clinic as we've been recording, and every single one's like, nope, it's too far. I don't want to deliver it. And it's 8:48, and someone's gonna leave that clinic soon.
Do you have to go get it?
No, it's like a 2-hour drive from here. No one will be there, and that's why the Uber every single one, because like I don't know about you guys, and I don't know how Joe does it, but horizontal impactions, I can't do it with the high speeds unless you have a really nice long burr. I always get in trouble with those because if my burr can't reach the root and it's an ankylose root, I'm toast. That's when I have to mute all my videos.
Right.
Yeah, the straight hand piece, no problem with those.
Yeah, I just extend the burr, or I'll just take the burr right. Like with my straight, I get really intimate in that socket, but with the high speed ones, I just can't do it. You'll see me doing acrobats with my fingers twisting and turning.
They
Trying
have
to
those
see-
impact air drills at the University of Washington. I teach there, like the dental students when they take out their teeth as 3rd and 4th years, and they have those same contra angles that you guys use. And those burrs are like this long; they're so short. I can't use them. I'm like, I feel like an idiot there. I'm like trying to help them out because they broke a root and they can't get it out. So I'm like, oh, let me help you out. I'm like sweating because I can't even like use that thing. I don't know. I guess you have to just use them enough to get used to them.
It's all about that angle. I was using one today, and you're hitting the 2 adjacent teeth, and it's like the bone's down here, but the burr's only like hanging in the wind. I know what you mean.
And it's like a
Yeah,
Tesla. Like you let go of the rheostat and like it just stops. It's like there's no like. It's just weird. It's just I don't know. I'm not used to it.
That's one of the instruments that they had us use in my first job at a residency were the impact airs. And I remember thinking, what am I going to do with this? I mean, now fast forward, it's still my go-to. So yeah, it's just getting used to.
Yeah.
I feel like
factor.
the burr stops in the tooth when I'm using it. And like just doesn't start again.
No, it's pretty. It probably is a bad handpiece, but they're pretty strong. I mean, they're pretty fast for sure. We'll go through anything.
But Joe, you use longer burrs for it. I've noticed that you actually have longer shank high-speed burrs.
I mean, they're regular for me. I've seen short ones before where you push them in and literally 2 millimeters stick out.
That's usually what I have, yeah.
Yeah, so I've got the 8-round burrs with the longer shaft, so it gives me access. I rarely have problems. I mean, if ever.
You use round burrs
Mm-hmm.
to section teeth
A
and
number 8.
everything?
Yeah.
Wow.
Yep, the same burr.
I've
Yeah.
never tried that.
Yep. I like it.
That triangle I'm using, it definitely stops against the tooth like every
Yeah.
half a second.
That's annoying.
You might need a new turbine, to be honest with you, because when that starts to happen, it's time just for a new turbine. I mean, if you, yeah, because it shouldn't do that. It's pretty powerful. I mean, I've got friends who, if you just Google 45 surgical on eBay, you can find disposable ones for like $30 each. I like the Impact Air, but you can find really inexpensive disposable ones on eBay. If you, like I said, if you Google or if you search 45 surgical. So there's like all kinds of options.
There is one I actually ordered, and a couple of the oral surgeons that I work with, they told me about it. It's called COXO. If you want to go around and do surgery and you want to just buy like 4 or 5 hand pieces,
Coxo?
like COXO. I know it's a weird name, but
Sometimes I'm 12.
Serv gets very excited with these kind of things.
You have no idea. Great.
But you can literally get one of these for like $170 or $150 US, and they work really well. And if you lose it, you're not going to cry because the other ones you're paying like $2,000 a handpiece, and like if you lose it, which happens when you go from office to office.
So those are yours. You bought all those and you just carry them with you?
I have a suitcase worth of supplies that I take with me.
Yeah.
Because once upon a time, I used to rely on the dental offices having what I need, and boy, was I wrong.
Yeah, if they're not using that stuff all the time, you're going to lose stuff there.
I know that the challenge with it is trying to get them sterilized and returned back to you before you got to head out.
Yeah,
sometimes that's the challenge.
You have to wait.
We're going to have to get you a portable sterilizer system in there.
Put it behind my car.
Yeah, put it in the back of your Ferrari. I would love that.
Just get a Thule thing on the top of your car and you just load it up there.
I actually never ever drive the Ferrari to work. It's like a big no-no.
Yeah, especially if you're driving 200 miles or whatever, 2 hours to get somewhere. It's kind of a...
It's not
so your daily driver is the 911?
No, I sold the 911 a couple of months back. I couldn't get another parking stall, to be honest. In downtown Toronto, trying to have extra parking is quite a challenge. I pay almost $500 a month for an extra parking stall. It's like crazy.
Oh my gosh, that's crazy.
It's crazy.
It actually sounds cheap. I mean, not cheap, but reasonable for what it is here too. That's crazy. I know New York's got to be ridiculous, but yeah.
So yeah, like I got rid of that one, but I have an SUV for the winter that I use now. So
Amir, they've got those electric bikes. I want to see you on one of those. You know, with the big knobby tires, just
with my surgical suitcase behind it.
Yeah, I want to see that.
Man,
no parking fees, get good on gas.
Driving here is so bad that it's honestly like a risk to your life to be on a bicycle in this city right now.
Yeah, I bet.
There's not a day that one doesn't get hit by a car.
Not good.
I'm hoping this Uber accepts my handpiece.
Hopefully it does.
Otherwise, tomorrow I gotta go with the Impact Airs.
I'm imagining now, like, you know, you walk out of the dentist office, and in the parking lot in the back is Amir back there with like a halal truck just sterilizing his instruments. You know, where it's got like the engine thing going in the back.
You know, I actually knew a periodontist that had 2 sterilizers in his parking because he would go around to offices doing surgery and then he would bag the dirty instruments, bring them home at night, and then bag them in his garage and sterilize it and then take it out the next day.
That's a lot of work.
That's a lot of work.
Yeah, no.
Here's my question. When you say surgery, are you talking just perio surgery or?
Yeah, he only does, I think, implants and perio surgery.
Okay, cool.
He's sterilizing the implants, so we're using them too.
I hope he's not watching this.
Those COXO implants.
COXO implants.
Nice. Was there any more questions people had? I feel like there was like some weird questions people had.
There was a lot of weird questions. Let me have a look at these. Are we going to cut these parts out?
You are? What? No, we're not. I'm not cutting it. I was just going to shorten the beginning until it
he's not a high editor for that. So you're live now, Amir.
Raw.
It's on you, man.
Maybe let's cut the Ferrari part out.
No, I want you to get a picture of a Ferrari, and that's going to be the thumbnail.
Oh my God, with all four of us in the Backstreet Boys outfits, just top down, sitting on top of it.
I gotta check out their other album covers, see if that happened. I don't know.
I like the one when you made though. I was going to use
That's
that
the
one.
best I could do. I can't. Yeah. Tried to farm it out, but no one had any ideas or could do it better somewhere.
I thought it was
It is
great.
what it is.
What do we need to do? There's no better than that. That's the best
No,
one.
I know.
No?
It's fine. It's fine. It's for free.
There's a really good one by an oral surgeon. He had put 1 or 2 piece bathing suits.
What? 2?
Is anybody we know
Honestly, seems like a round burr kind of guy, you know?
based in Nashville, Asian?
Oh, is that you?
Yeah, that was me.
All right, fine.
We'll edit that out. We'll put that on Serv.
Okay, so post-op regimen for medications, pre-op analgesia, and use of steroids. That's a good one.
Okay, I like that one. Brendan, what do you do?
I missed that. It just said Joe's recording stopped, but now it just started again. I missed the questions. Sorry. And I got 5 minutes. We're good. 6 minutes.
Okay.
7 minutes. We're good. 6, 7 minutes.
So what do you guys usually prescribe post-surgery? And any pre-op steroids or post-op steroids or any pre-op medications?
You want me to go? Okay, sure. Operative, if it is all 4 wisdom teeth and there's a significant amount of drilling, maybe coronectomies, I would go 5 of oxy, maybe 8 tablets for 2 days. And then just, 600 ibuprofen for 7 days, 500 Tylenol for 7 days, and then maybe the amoxicillin, if there's significant drilling. Or as far as steroids, I would just give that if we see some neurosensory deficits at the post-op visit 1 week out.
How about you, Joe?
Go ahead, Joe.
I'm not a steroid giver, so I don't use them at all whatsoever.
You don't put it in your IVs?
No.
No?
No, but the extent of the steroids I use will be, for example, on the topic of nerve damage. If a patient comes in with paresthesia a week later, I'll give them a Medrol dose pack. That's pretty much it. Yeah. But for thirds afterwards, no, it's just not something I use.
Can I ask why?
I mean, there's benefits to it. I've read and seen that. I guess just in my hands with the population of people I see, they seem to do fine without it. Just a non-steroidal anti-inflammatory, I think is effective, but just a prescription steroid, I don't see a benefit to my patients.
And how about you, sir?
For routine wisdom teeth, I give in the IV, if they're IV cases, I'll give 8 milligrams of dexamethasone per case.
Zofran too, or just dexamethasone?
Zofran, yeah, I've been using Zofran because now that I had Precedex, like for a routine case of wisdom teeth, a lot of times you end up giving a fair amount of medication, different kinds, right? You're titrating things. Not everyone gets the same doses. It just depends what works, right? So it's like a Versed, which is midazolam, Precedex, fentanyl, ketamine, propofol, dexamethasone. That's 6 agents right there. So at the end, I do give like 2 milligrams of Zofran. I don't use the 4 milligrams, and my reasoning is it's more preventative. It's not like they're actually having nausea, vomiting, where I give them 4 milligrams of Zofran. So I give them 2 milligrams of Zofran, and but that's a routine case really for me. So seems like a lot, but it's little doses, and everything works out really well. The Dex helps with I use it just because obviously for swelling and things like that, and I think it helps. But
yeah, in the rare case that I'm in the OR doing teeth or whatever the case may be, if I have access to it, I'll give it. But in my office, it's not something I do routinely because I know there's benefits, but I just don't prescribe that.
Interesting.
Is there another question we could hit on? Or?
Let me give you guys one more, and then we can let you go.
I don't want to go. My Wednesdays, I'm packing up the Wednesdays. I'm going to try to do podcasts one night a week, and I think Wednesdays are going to be it. So, fellas, we could lock in a time for Wednesday nights if you can for the future.
Yeah, I think it's great if we have topics too. That'd be awesome.
Yeah.
I should have ran the questions post one more time. I think I should have ran it at least one more time.
No, we can do.
Where like if someone posts and then you tag everyone else's ats, we could repost it and then do our own question blurb for people to submit on top of it. And if in the background we could put like the BackTeeth Boys cover photo, right? Then people recognize it.
I wish that was an NFT. That'd be sweet. Get that going.
We could get the BackTeeth Boys. We could get Dr. Amir's halal truck sterilizer in the back. We could get some good NFTs going on these, right?
Halal
truck. Shawarma mobile.
Halal truck. That's so good. There was one more about paresthesia and the management and when to refer.
That's meaty. We've all had cases of this, even recently. I know that.
I had one,
including myself. I mean, I did a podcast on this. I'd give those 3 antioxidants right away, and I reevaluate them in 30 days with neurosensory testing if there's any paresthesia. And there is good data for those. They're used for various reasons for nerve issues, even neuropathy, things like that. So that's why I do it.
At what point would you say it seems like it's not going to come back?
I mean, normally you tell the patients, what you get back after a year, if after about a year, like what you're going to be left with is usually going to be permanent. You get most of that back within that time. And after about a year, you're not going to get much more back. So I would say in our literature, I think it showed every 2 months. If it's a really bad sensory deficit, you want to refer them out if there's any surgical, issue. But yeah, so
I recall the windows are at 30 days and at a year. So if at 30 days, you follow them up for serial mapping, and if there's no change and subjectively the patient doesn't like it, maybe it's turning into more of a dysesthesia. At that point, for sure, I think it's a good idea to refer them out to a nerve repair specialist. I've had to do that for consultation twice, and they ended up not having the surgery. Of all these years, so it's rare. And then what I'll do after the 1 month is I'll have them follow up in about 6 months, and usually it's started to come back at that point. So I've not had anybody who hit the 1 year mark that I've had to refer out.
Now, here in Canada, I believe we don't have a Medrol dose pack. What would you suggest as an alternative?
I like prednisone. 10 milligram tabs. You can start maybe 60 a day, 60 milligrams a day, and obviously a taper over maybe 10 days. Yeah, exactly. So Medrol dose pack is pretty mild, but if you need something with a little stronger, I recommend prednisone, 10 milligram tabs, just with a drop down dose.
Was it like 6 days? 6, 5, 4, 3, 2, 1.
Right.
I usually do that with Dext. I do 8 milligrams, 6 milligram, 4 milligram, 2, and 1 and 0.5.
More important than when to refer the patient out is to make sure you've got real good notes at 1 week follow-ups. So if I have a patient comes in and they say, my lip is numb, I say, you and me are going to see each other once a week for the next month. And then they come in and then you do your 2-point, you do your direction, and you document that, and you make a little drawing, a little picture. And then after 4 weeks, you can see, hey, your 2-point has improved, your direction is better. Maybe they report they're starting to feel cold. And just seeing that sequence, in my opinion, is the standard of care. So whether or not it happened or it didn't, like I've told you, Amir, that's not necessarily evidence of malpractice. You just have to be able to manage it and know when to refer it out, and it happens.
Yeah, it's in the consent form.
Before we go real quick, is there any technique or difference in the procedure that you could recall that might have caused the paresthesia?
My experience is it happens the most benign, I had no idea type cases. And usually the hard ones, the patient comes back completely fine. But it's the ones that come out pretty simply that are just, so to answer your question, I can't really predict, to be honest with you. It's usually unexpected.
Yeah, I had one case, I just got a wisdom tooth out with forceps, and literally elevation forceps, no drilling, and paresthesia, so it happens.
But it's likeliest with age, but I had a pretty decent one on an 18-year-old. It started to come back after about a month, but I would not have predicted it for sure on that case.
One thing I noticed in residency, every single paresthesia, there might have been one that wasn't this, but every single paresthesia case, it was working with an attending that when you made your flap, you open up the buccal side of it so you could see the area you're going to trough it. And then sometimes, you kind of undo the top so you can see the roof if there is bone on the distal of that tooth, right? That impacts the tooth. But this attending would want you to dig down under the periosteum, right? Always under the periosteum, but dig down onto the lingual side.
And then lift
cortex,
up.
And then, but like would slide it down there almost like a centimeter and then kind of inch it forward. Now, I get it because it protects, going into the mucosa and the gingiva on the lingual side in like the site 32 or 17. But that's what caused the paresthesia every single time, doing that. I just don't do it anymore. I just stay away.
That's a high lingual nerve, which can happen in anatomic variation. Yeah, for sure. I've seen one run through the... Amir's even showed me once, like on Instagram, someone was using cautery to make their wisdom tooth incision. Like literally like electrosurgery. Remember that? And like he was making it...
Right in the path too. Right in the path of the lingual nerve.
On the lingual, and like clearing the tissue off with cautery. It looked cool. But there's a freaking nerve somewhere there.
It's like cool too, huh? In a month.
Bleeding.
Once I raised a flap, and usually, so the oral surgeon that trained me back in Australia, he always did what Brandon says. He had a reflector specifically for the lingual tissue. And every time he would flap, he would get this reflector then and slide it under the periosteum and whoop, lift up the lingual tissue right away from the bone. So I went to a lingual nerve injury lecture once, and they said that is the number one cause of lingual nerve injuries. It's the old school surgeons that had trained raising lingual flaps that always caused it. And it's funny because one case I was doing, what I do is just on the crown of the tooth, and I think Serv and Joe, I see you guys like do the same thing. Sometimes I'll just put the blunt end of the periosteal just right on the crown of the tooth and just slowly lift up the tissue a little bit when I want to trough. Right?
Little peekaboo.
Once I lifted it up and I just saw a fat nerve just right on the crown of the tooth. I took a picture. I think I showed it to you. The lingual nerve was literally like 3 millimeters away from the crown of the tooth.
Yeah.
So you could have literally just stretched it.
And that's like the worst one to have an issue with. Inferior alveolar is manageable in a lot of cases. That lingual one is the tough one.
Would you rather bite your lip the rest of your life or your tongue the rest of your life?
It's that plus the dysesthesia people more often get with lingual nerve issues. I feel I've seen. That's
and the loss of taste.
So much work.
The pain.
Yeah.
That's painful now,
Yeah.
So,
All right, guys, I do have to hop, but this was just phenomenal.
Yeah, it was
we'll
fun.
get back together. We'll bring the BackTeeth boys back next week. We'll bring it back.
Sounds good.
We gotta get sort of one of your little button things on the side. BackTeeth, back. All right. And then we like hop into the podcast.
I wish chat did audio, but who knows? Who knows? Maybe soon.
Yeah, like those dancing elves where you put somebody's face on there and they're doing this dance routine. Yeah, that would be. No, okay.
No.
It would get clicks. You're about clicks. You're
gonna take your ass back to Facebook. All right.
All right.
All right, guys. Good night.
Have a good night, guys.
All right.